I'd like to educate you just a little bit about costs in doing medicine. When someone quotes you a price to do a procedure, I think it's important that you're able to compare apples to apples. And I think it's important, especially since there's going to be trials starting in Canada, that when they start talking about costs, you have a better understanding. And the person asked Dr. Code about $1,500. That's about a price that the doctor would actually get paid to do the procedure. What that price doesn't address is the cost of the facility, the cost of all the equipment, the balloons, and everything else. And I can almost guarantee you that if you did look into how much it would cost to do a patient in Canada, if you add the doctor cost to the cost of all the equipment, it'll probably come up close to $8,000. And so, you know, when they are throwing $1 million at a trial, and they come out and they say, we've only done X number of patients, and you're doing the math in your head, keep in mind that it's really not $1,500 to do the procedure. It's probably multiple times that once. For instance, a stent just by itself costs $1,000 to $2,000. Just that, a balloon, the high pressure balloons that are used, one of those balloons costs about $400. And typically in one of these procedures, we can use upwards of, in some cases, we'll use 15 to 20 of those balloons.
I had a friend went to Mexico. She paid $1,000 for every balloon. She had 13. She had her base cost first. Know what you're getting into. Stints, the same. Some people will charge you so much for each stint. You know, in some places we'll charge you $2,000 if they need stints, but you'll get as many as you need. I'm not trying to push stints. I don't think there's any reason currently to do stints in the jugular vein. We know more than we did. If we treat the valves, we hardly ever need to stint the jugular vein. That's my suggestion. If Joseph wants to disagree.
No, I agree fully.
Yeah, no, so he agrees with that. Fair enough.
Other than that, that's the only kind of...
The other part of the research coin, and I've done Canadian research in Canadian universities. When you do research in Canada, you don't have to pay extra to the universities. When you do research in the United States, you must pay another 30 or 40% administrative cost to the campus. It's a very different kettle of fish up here. And we're living in la-la land, and lots of these people have never done a little bit of research, and they don't know what they're talking about.
I've got the... what do you think about...
There is a lady here who likes to know how she can get your book.
All of the books up here after. I've got about 30 of them.
What do you think they're going to accomplish from putting in $1 million in an observational study?
You mean like we're doing currently?
Yeah, like Alberta is doing, well, supposed to be doing.
Well, I mean, they're buying time. They're trying to get the heat off themselves by the $1 million observational study. I would suggest to you it's tricky to do an observational study the way they're talking to. I mean, Newfoundland brought it up right early, okay, that they were going to do a registry. Neurologists would see them before they went, they'd see them when they got back and document it. The early data of observational study, I would rather they didn't go back and look at the observational data because the system and the quality of care has improved the last 6 months. Lots of centers are still not treating the valves. I don't want data from that because that will support the naysayers. I want modern data with optimal treatment to be done. And so that's still going to be a gray zone. There's enough people will improve probably. You know, the early saying was a third improved, a third a little bit better, and a third no better at all. And you even get into worse. I don't buy the worst stuff. I don't know how the intervention in testing could make you worse. It really is beyond my belief. But, you know, maybe you get unlucky and block the only valve vein that was working, sort of idea. And then it was even challenged more. But that was early days going on when we weren't optimal how to do it, and people were learning how to do it. And most of the Canadians were in the early days of that. Fair enough. We know more now. Let's get on to the trials. There's 6 trials already happening in the United States, and this is only delaying tactics. This is absolute nonsense that we're going to repeat the wheel when we know it's 86 to 97% of folks with MS have it under anybody's criteria. It's a joke. And the registry that we just announced in Canada, that's a comprehensive registry. That's all MS patients, all treatments, And all that's going to be do is a muddy water collection system. Again, it's smoke and mirrors because it's not going to do enough detail about how the treatment was done and how people have done before and after. And the crude method they're going to do in that score, they're going to do the EDSS. How many of us have had those sophisticated fatigue tests or quality of life scores? I've never had one. They've done EDSS. I'm still a 0. So what's that do?
I just have a question about the difference between the angioplasty in the veins versus arteries. I've heard people say, well, they've been doing angioplasties for years. My understanding, now after Dr. Hewitt talking, that they've been doing a lot more in the veins than I realized, but the difference, that they're two different beasts, arteries being elastic and can handle, they're totally built differently than the veins. So is there something to be said for the fact that, like, do arteries, when they're ballooned, stay open easier and longer than the veins do? Is that part of the issue why people get restenosing?
I think that's difficult to say because in a sense you're comparing apples to oranges. Arteries have smooth muscle in the wall. What I keep coming back to is the fact that veins have been angioplasty for decades. And there's very well-established methods of angioplasty veins. If you look at dialysis patients, for instance, patients who are on dialysis have fistulas and grafts. And some of these people get angioplasty twice a year, for years, decades in fact. We have a very large dialysis population in our practice that we do thousands and thousands and thousands of venous angioplasties on every year. So to say that veins do not respond as well to angioplasties, I don't really know how to answer that question. It's comparing apples to oranges. And everybody's different, Some people, quite frankly, you will angioplasty them. I can speak quite clearly about dialysis patients because we do so many of them. Some people we will angioplasty them and we'll need to have them back 6 months later because and some people will angioplasty them and it'll be years later. And they have their own set of medical conditions that alters how they heal and how they form scar. But I think in some ways it applies to CCSVI patients. Depending on where you perform the venous angioplasty and how you perform it, and other things like nutrition, for instance, these will be variants on how the angioplasty will respond.
I think just to add to that, the problem is in Canada, most of us as physicians don't know that venous angioplasties have been done for years. Okay? I trained in Saskatoon. I was on faculty there, late 80s, early 90s. We weren't doing angioplasty of veins for renal patients. In fact, I don't think they are even today. I'm not sure if they're doing them here in Canada. In Canada, we've got 88 interventional radiologists. If we started doing the MS patients tomorrow, it would take us 10 years. Just if they only did MS patients. Because they haven't had it in their training, and they don't go to the surgical meetings, and they don't go to the interventional radiology meetings, they don't hear about it. So they're only going on less information than you have. Knowledge is power. By the time you've left the room today, you will know more than almost any physician in the country. I'm not trying to brag, but the issues are out there, and we know. But I learned a long time ago when I advised people about nutrition, they go and see their doc. Their doc says, well, I'll do that, or you can do that when there's evidence for it. Well, there is evidence now, but their concept of evidence is evidence that they've heard. And some of them aren't even interested in going to look or reading the article you brought in. It's tough. Time is short when you're with your physician. And if you think that they're spending a lot of time thinking about you between times that you're in there, get over it.
I'm asking a question for my vocally challenged friend. It's a two-part question. One is that why isn't it just common sense for a lot of people who are afraid of looking at this theory of separating it from MS from the idea that we just need good, proper blood flow in our bodies?
Well, it is make practical common sense to me now. But I was hesitant starting in. I was a year and a half. I was at least a year getting my procedure done from when I embarked on the journey. at least a year, okay? And it's a change. And the autoimmune has been pushed so long, the autoimmune's crumbling right now. Dr. Hubbard, neurologist from California, who got into it because his occupational wife pushed him there because of their son having MS, says there is not one true shred of evidence for the autoimmune system in MS. But it's going to take a while for that acceptance to occur. But it's turning up now in editorials. And so it'll start to get out there. But, you know, dogma that's been around, paradigm shifts are tough. The classic paradigm shift, even taught in MBA programs, is the ulcer problem with ulcers being created by bacteria. Dreamt up initially 2 GPs in Australia. They went through hell. They were 20 years before now they're accepted. Got a Nobel Prize.